Good afternoon. My topic is differentiating dermolipoma from subconjunctival fat prolapse on magnetic resonance imaging. So, it's not working. So for starters, differentiating ocular dermolipoma versus subconjunctival fat prolapse. Ocular dermolipoma is basically normal tissue growth in an abnormal location. It is basically contains the connective tissue and adipose tissue at the temporal fornix. It is a yellowish white small mass adherent to the conjunctiva, and usually it is asymptomatic, usually detected in adulthood. It is an uncommon benign tumor constituting about 4.2% of all conjunctival lesions. It is congenital and it occurs in and under the bulbar conjunctiva, usually at the temporal fornix, that is at the lateral canthus between the superior and the lateral recti. It is a congenital, basically choriostomatous tumor. The symptoms can be something as basic as a mechanical irritation, but it can also progress to larger size lesions, which may cause astigmatism, and also the cosmesis is also a factor. Versus the subconjunctival fat prolapse, which is basically an acquired lesion due to herniation of intraconal fat due to weakness of the Tenon's capsule by aging, trauma, surgery, or a combination of these factors. The fat which is mainly responsible for the neurovascular integrity and which is also provided by the tenons, that all may be affected and it may lead to the prolapse into the subconjunctival space. It is contains the fat, fibrovascular septae, and inflammatory infiltrates. It is seen in elderly obese men and presents as a fat containing epibulbar mass, again in the lateral canthal area. Anterior margin is convex and may show the presence of fine blood vessels. The common point between both of these is both are located superotemporally and do not involve the cornea. So I'm going to be presenting a case of unilateral dermolipoma in an otherwise healthy adult male and is to be differentiated from a subconjunctival fat prolapse. A 60-year-old diabetic patient who's with uncontrolled sugars was presented with a superotemporal swelling of size 2 centimeter to 1 centimeter in the right eye, which is soft, cystic, yellowish, freely mobile, non-tender, having convex anterior margin with superficial fine blood vessels. It showed prominence on convergence. There were no other factors like redness, pain, watering, no history of trauma, discharge, any ocular surgery in the past, or any ocular usage of any topical medication. No other systemic features. The aided visual acuity was 6.6. The anterior segment and posterior segment were both evaluated along with a dilated fundus examination, which was also essentially normal. A provisional diagnosis of dermolipoma or subconjunctival fat prolapse was made. As you can visualize in the images also, the typical lesion is what we can observe. This is the basic, the visual acuity could be 618 improving to 6.6, and the projection of rays was accurate in all the 4 quadrants. The refraction is provided. Rest of the anterior segment was normal. Only the conjunctiva showed a superiotemporal palpable and fornicial well-defined swelling near the lateral canthus of size 2 centimeter to 1 centimeter in the right eye, which was cystic, soft, freely mobile, non-tender, and had superficial fine blood vessels. The rest of the anterior segment was normal. The intraocular pressure was 14 millimeters of mercury in the right eye and 16 in the left eye on a Goldman application tonometry. The fundus was also normal. The MRI imaging that was done without contrast showed a well-defined altered signal intensity of 1 centimeter into 0.3 centimeter at the superotemporal aspect of the right epibulbar area. The important point being it was not continuous with the intraconal fat, and a sliver of well-defined crescent-shaped lesion was observed, which was hyperintense on T1, T2, and hyperintense on T2. Rest of the orbits, optic nerves are within normal limits. So we confirmed the diagnosis of dermolipoma. So the diagnosis of the patient was in a case of diabetes mellitus 2. It was a refractive error with dermolipoma in the right eye, and left eye was nucleus sclerosis grade 1 with cortical cataract with refractive error. Management of the patient included the investigations and the management. The systemic investigations were done. Yes. So basically, we did the conservative management of the patient and the proper refraction and lubricants, and he was asked to review. So basically, we need to differentiate between the two because their location and the presentation is quite similar, but we can differentiate on the basis of the magnetic resonance imaging. So in our case, it was dermolipoma because the treatment of both is different and we need to accordingly identify the same. total excision is contraindicated in the case of dermolipoma. So basically, we need to identify all the conjunctival lesions and other ophthalmologic anomalies, especially in the patients, diabetic patients especially, and these are my references. Thank you.
Thank you. So what is the value of doing MRI? What was the indication?
So basically, both these lesions, like I said, they have a very similar presentation. So to identify whether it is
How does it make a difference? आपने तो conservative ही करना है.
yes, sir. But if it was
See, the MRI or whatever the diagnostic test you do, it is going to cost. Yes. So therefore, if we are not making a major decision about treatment or prognosis, then maybe investigation is necessary or not, something that you should question.
And it may not be correct to say that MRI confirmed the diagnosis of dermolipoma, because any of these diagnoses is ideally histopath. So confirmation never happens on imaging. Clinical correlation is needed.
I think that's a very valid point, sir. I mean, like, we have to think of the economics of the patient. But thank you.
Thank you very much.
thank you.